Hello, welcome to today's presentation, The Future of Breast Cancer Screening, 3D Mammography, presented by Dr. Sunil Upender, radiologist with Washington Radiologist Medical Group. Dr. Upender graduated with honors from Wesleyan University with a major in biology. He graduated from the University of Vermont College of Medicine in 2003 and did his radiology residency at Norwalk Hospital, a Yale University-affiliated institution in Norwalk, Connecticut. Since 2009, Dr. Upender has served as the Medical Director of Imaging, Chairman of Radiology, and Radiation Safety Officer for the Washington Radiologist Medical Group. Outside of work, he enjoys staying active by cycling and kayaking and spending quality time with his family. Please welcome Dr. Upender.
Hi, my name again is Sunil Upender. I am a radiologist and by training, and particularly I have a special interest in breast imaging. That is what my specialty training is in. So I'm happy to be talking about this topic today, basically breast cancer and imaging for detection of breast cancer and prevention. So let's just start off with some basics, some statistics. Basically, breast cancer is the second most common cancer after skin cancer. In America, 1 in 8 women have a chance of developing breast cancer in their lifetime. So odds are someone you know will have or has had breast cancer. So it affects all of us. It also has the highest death rate after lung cancer. In 2025, it's estimated that 316,000 new cases of breast cancer will be discovered, and this is invasive cancer. And then there's an additional about 60,000 cases of more localized cancer. So again, just proving that it's a very common disease. And you know, there are fatalities. 42,000 women are expected to die in 2025 from this. Now, it's not all doom and gloom. There is definitely hope. There are 4 million survivors that are in the US right now walking around and are fine. And the key to that, this is just one more statistic just showing how common it is. You know, basically every 2 minutes, a woman is diagnosed with cancer, and every 13 minutes, a woman dies from breast cancer in the US. But again, going back to the point of hope, the survival rate is excellent if it's found early. So as this graph here on the left, you can see if the cancer is found early, there's nearly a 99% survival rate over 5 years, which is excellent, obviously. The later you find the cancer, such as in this column, which is the cancer is spread locally, or distant spread of cancer, then survival rate decreases quite a bit. So as you can see, we want to catch everybody here early. And then, you know, of all those numbers that I shared, then we could save a lot of people. And so that's what we're going to be focusing on. And, you know, what we have done over the past 50 years has been 2D screening mammography, which many of you may have had. And that basically gives you 2 views of the breast, and that's been our main tool to combat breast cancer. And that's been quite successful since its advent in the late 70s, 1970s and forward. There has definitely been a mortality reduction from breast cancer. So with the advent of mammography. Now, you know, there's been numerous studies looking at mammography, and this one big study in 2019 by one of the gurus of breast imaging kind of had a simple question, which, you know, addresses a lot of women's main concern is, all right, I'm getting this mammogram, is it really going to help me survive, or am I just going to get cancer either way, or will I have been healthy either way? So just a simple, straightforward question. looked at over 50,000 women over a 50-year period roughly, and basically looked at women that were getting mammograms and those that were not. And the data clearly showed that if you at least do a mammogram every year for 10 years, you have a 60% lower risk of dying just from breast cancer. And if you stretch that out for even more years, still a great 47% lower risk of dying. So, you know, it's been established, and that's what the current tool is. There are limitations with 2D mammography, and you know, this picture might be hard to see, but that's how often radiologists we feel when we're looking at a mammogram. It's looking for a polar bear in a snowstorm, which is what this picture is, if you could depict that. And you know, basically saying that it's not a yes or no test. We look at a mammogram, but it's just not visible sometimes, regardless of how excellent the positioning is, how great the radiologist is. It's still 30% of cancers can be missed. And the more dense your breast is, the greater the chance that we may miss some of these things. Additionally, there is something called callback rate. And what that means is sometimes we can say, yes, there's cancer, no, there's no cancer. Sometimes it's an in-between, and we'll have a patient come back and take some additional views, and that's called callback. And obviously that creates a lot of anxiety, because you're not sure what's going on till we take these additional pictures. So we want to try to minimize that. But that is also a limitation of the study, is that we're not 100% sure even if we do see something. Going back to the density issue, here are two pictures of a mammogram. The one on your left is what we call a predominantly fatty breast. There isn't much dense breast tissue, breast parenchyma. On this right side, there is a lot of dense breast parenchyma. And again, going back to that polar bear analogy, there is a cancer here, and yes, it's kind of visible with the circle around it, but there's a lot that could be missed in here, and it's also hard to see this. But on this fatty breast, you can see the smaller cancer more easily. So obviously, the more dense it is, the harder it is to see. And because of that, many states, including California, have a breast density notification law. And that's been in effect for several years. And basically, it requires us as radiologists to not only look at how dense a breast is, but to record it on the report and notify the patient how dense their breast is. Because there's two things. There's obviously the more dense it is, the harder it is to see, as we saw in that prior image. But people with dense breasts actually have a higher risk of developing breast cancer. So it's a double whammy where it's harder to see and they're more likely to develop breast cancer. So clearly it's an important topic, so that's why it's required to put this in our reports. And here's some examples of what you may see in your report, basically saying that your breast density is you're either dense. It's on a scale of 1, 2, 3, or 4, and basically a 3 and 4 are greater than 50% dense breast parenchyma, and that's considered dense. And basically just saying what I mentioned, that it's harder to evaluate, you have an increased risk of breast cancer, so talk to your physician about different options. And what are our options? There's different screening options. MRI is one technique. It's a great test. Unfortunately, it's not great for a screening population. It's not widely applicable to the masses of the whole country because it's an expensive test, for one, and then it also takes a long time to perform the exam. So it's just not feasible to screen every patient every year with this exam. Another screening exam is ultrasound screening, and that also shows some promise, but unfortunately that is also operator dependent, and there's a lot of false positives. And so we go back to our screening, which is our screening mammograms, which is our best way of looking for breast cancer. And so what I'll be talking the rest of the talk about is screening tomosynthesis, which is kind of our best current option. And it's also called 3D mammography. They both mean the same thing, and it is different from the conventional 2D mammography. And there's a number of advantages. The main thing is we're able to see different lesions, we'll see them better, and then we're able to characterize them better, say, hey, this is cancer or not. So one will have to bring you back, so that callback rate will be less. As I mentioned earlier, that we want to keep that down just for anxiety and stress. So the better we can see something and decrease the callback rate, that's better. Obviously, we want to increase cancer detection rate. That's the whole reason we're doing that, and Tomo has proven that that is the case, and also increases its positive predictive value. So, what is it? It's a typical mammography system. This many of you may have seen this if you've had a mammogram. It's got the X-ray machine here on the right, and this is where the technologist performs the actual image acquisition. This is where the patient you would be. And so it looks the same as it always did. You take two views just like before, so in concept it seems the same to the patient. There is a little longer. Each picture does take a little bit longer than usual, about 4 seconds per view, and so you would need 4 views for the bilateral breasts. Now the difference is that in the technique, where the camera actually makes an arc over the breast, 15-degree arc. And basically, here's down on the bottom is a schematic of a breast, and it's just looking at it from different angles. And it creates these multiple images that are looking at it from different angles, and it takes that data and processes it and creates multiple slices through the breast. So that's ultimately the goal, and that's where the 3D concept is. Instead of looking just at one flat image of the breast, we're looking at multiple slices, fine slices through the breast. And so we may be able to see tiny things that we couldn't have seen before, and then we'll also be able to distinguish a lesion from normal breast tissue. And here's just another schematic showing that. Here, this gray circle is just normal breast tissue. This little star-shaped thing is a lesion. And so it just shows that if you look at it from an angle, you may actually see these two lesions. But if you just looked at it from top, the breast parenchyma would cover that cancer. So that's kind of the concept. You're looking at it from multiple angles. Here on the right is a conventional 2D mammogram. And you see all this breast parenchyma. There is a lesion that's here, and it's hidden, or you could see it with the arrows there, but basically the point is, with this 2D image, maybe that's something, maybe it's not. With this slice here, this is one of the many slices through the breast on the tomo, you see this cancer nicely depicted. Again, here's another example. This is a 2D image, and there's a lot going on here, but on one of these slices, you can see that there's a cancer right there. And again, as I was describing, normally we would bring this patient back if this was just the mammogram we'd have, because we're not sure, is this something, is it not? It kind of looks like some of the cancers we looked at in the prior films. So instead of bringing the patient back, we can just scroll through all these different slices and see what we see in this image is that there's actually nothing there. It's just breast tissue on top of each other that gives this suspicious appearance, but it's actually nothing there. So that's that's great. The patient doesn't have to come back, and we can clear the exam. Just showing you some other examples just so you see it again. These are some of the representative images through the breast. And then we see something on one slice that we may not see in another slice, and that ends up being cancer. Here's another example. This is that 2D image, and then this is the 3D image showing this spiculated cancer that you can see in retrospect here, but how do you differentiate that from all this other tissue, which is normal tissue? Now, one of the benefits, a recent change, is that we've been able to take all this data, all the slices, and the computer will basically create a 2D image. And and you may wonder, why are we going back to the 2D image? We want to look at both images because there is some value to the 2D image. It does give an overall gestalt of the breast, and also helps us compare it from different years. So it used to require another X-ray. So you'd have to actually get the tomo image, and you'd have to get a 2D image. And obviously that the main concern with that would be it's twice the radiation. But now, because of computer algorithm, it's all done automatically. And so here's a 2D image, and here's a synthesized 2D image with no more radiation, but it can create that image. So again, no additional radiation, so it's a nice new tool. And this is a little biopsy device that's attached right here. This is just showing that if we do see a lesion, we may need to biopsy it at times, and that will help really figure out what something is. Is it something, a benign growth, or is it a cancerous growth? So the machine is set up for that. And sometimes, like in this lesion, there's these little calcifications that are oriented in a suspicious manner in this mammogram. And we only see that on 1 or 2 slices. And so we can go exactly to that slice and put this needle in and sample that area. So, the scientific community has been excited by this, but also wanted to prove that this is efficacious. And so there's many, many studies. I'm just sharing a couple here. This is a big one with 12,000 women looking at patients that underwent 3D mammography. And basically, the bottom line is there was a 40% increase detection of breast cancer. Additionally, they were basically finding more cancers, and false positives were decreasing. So those are cases where we thought there might be something, we do a biopsy, and it's negative. So that it's good news that it's negative, but again, we want to try to avoid all that for, obviously for comfort and anxiety issues, because we don't know, during that period whether someone has cancer or not. Now, this is a big study that looked at nearly 500,000 women, and again, the results were just as promising, basically saying that recall number that we want to keep down, this got better by 15%. Cancer detection got improved by 40%. Positive predictive value for bringing someone back. I mean, we still do have to bring patients back even with tomosynthesis, but when we do, we're a little bit more sure that there's actually something wrong there. There are a couple disadvantages, just to let you know, the main being that the image, since it's taking multiple angles over an arc, it does take a little longer, 4 seconds. So basically twice as long per image. The whole process, you won't feel the difference because it'll take the same amount of time, but that is one downside. Looking at calcifications is a little bit more challenging, but again, we get that 2D image that we create, so that helps with that. And then lastly, interpretation time for the radiologist, but that's time well spent, is how I feel, because it's making me more confident that I'm not missing anything. So in summary, 3D mammography, tomosynthesis, has been a great asset here at Washington Hospital. We've found many, many cancers that we probably wouldn't have found with just 2D, and obviously we wouldn't find without doing mammography. So I highly support, and the scientific community supports, getting an annual mammogram after the age of 40. There are some differences in age starting and ending, depending on patient's situation, but usually the recommendation is start at age 40, get a mammogram annually, and you can stop once, basically never. You just keep doing it because there's always a chance you could find something and help someone. The main reason is if you're not going to do any therapy, then if you're too ill from other issues that you may not do anything for this breast cancer, then obviously it wouldn't make sense to do a mammogram. But otherwise, it's proven beneficial in all age groups and in all breast densities, which is another concern. And that's about it. So I will take any questions at this time.
Thank you, Dr. Upender. We have a few questions. The first is the amount of radiation received from 3D mammography different from 2D mammography? And is that exposure to radiation safe?
Great question. So the 3D mammography is basically comparable to a 2D now. It used to be that it was twice the radiation, but now since they've been able to recreate those 2D images, which are important still, so basically you're getting a 2D and 3D, but it's at the same dosage. So, so no more radiation. And the radiation that you get from a mammogram is very, very minimal. It's just a tiny fraction that's used, especially compared to a lot of other imaging that we use. It's a tiny bit. We understand that it's an annual test and women are anxious about that, but flying across the country is multitude of, creates more radiation than just one mammogram. So it is minimal, and studies have looked at it, and it's clearly the benefits outweigh the theoretical minimal risk.
Thank you. The second question is, if I do my annual mammogram, do I still need to perform a self-exam?
Yes, there is some controversy over this. There's different committees that say you should or should not do self-breast exams because the data hasn't been fully there, as some of the data that I've shown here. Partly because, the self-exam, you're not trained, you might find other things that may be normal. So the community is still a little, they haven't come to a consensus on this. My personal experience, I think the more involved in your own breast health you are, the better. Both from self-exams, from your physician doing an exam, and then obviously the screening mammograms. Because I've seen scenarios in all three of those where something was not seen by mammogram, for example, but the patient can definitely feel something. So just from a real life perspective, I feel like yes, you should continue doing self-breast exams and then bring that to your physician. And then, then we could address it, whether you need an ultrasound, a mammogram, or if it is something normal that's been there. So I agree that you should do both.
Thank you. Our final question is a 3D mammogram more painful than a regular mammogram?
So unfortunately, the mammogram does require compression to get those views. So the breast is compressed in a plate. But it is the same as a routine mammogram, the 2D mammograms that you may have gotten. So it's not comfortable, but it's the same. And just because we really need the breast not to move. And again, the reason for it is just kind of like some of the pictures showed. You want to, there's going to be a lot of tissue that's superimposed. So the more you can spread it out, the better it is. It does, with 3D, we are, as I showed, there's less recalls, so we're more confident that there isn't something there. But the better the compression, the better it is for the exam. So it's comparable to 2D. Thank you.
Thank you. This concludes our program. Thank you, Dr. Upender, for this insightful presentation. And thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.